Welcome, everyone, and thank you for joining us for the second session in the Doula and Perinatal Community Health Worker and Medicaid virtual learning series. My name is Dr. Jennifer Moore, and I'm the founding executive director here at the Institute for Medicaid Innovation. I'd like to begin by thanking our partner, Every Mother Counts, as well as our funder, Community Health Acceleration Partnership, for their commitment as funders to advancing important perinatal health topics in the Medicaid population. Through their generous and ongoing support, we're able to offer this free national learning series to each of you. This learning series brings together Medicaid stakeholders, including state Medicaid agencies, Medicaid health plans, and provider groups. We have representatives from 48 states, the District of Columbia, and the federal government coming together with the shared goal of increasing awareness of implementing doulas and perinatal community health workers and Medicaid, by applying key findings from both IMI and EMC's landmark reports, their national, state, market, or local clinical setting. Now let's get started with today's session. And to help get us oriented, I'm going to hand it off to my colleague, Yanti Wheeler.
Thank you, Dr. Moore, and good afternoon, and welcome to our participants. This series includes 8 monthly 1-hour Zoom sessions. Topics will address relevant policy issues with pre-session materials, supplemental resources, and invited subject matter experts. Sessions are recorded and will be archived on the IMI website. All attendees are automatically muted. The chat feature is disabled. However, we have reserved time at the end of the session for you to ask questions for our guest speakers. To participate in the discussion with the speakers, please use the Q&A feature to submit questions and comments. You can submit questions throughout the session. The questions will be consolidated and shared by the moderator during the Q&A portion of the panel. At the completion of each session, you will receive an email message with a link to complete a short 3-minute feedback survey. As a reminder, completion of the survey is required as part of your participation in the learning series. We actively review and incorporate your feedback into future sessions. We look forward to hearing your thoughts. Finally, all materials will be available to you on the IMI website about 2 weeks after the session. Today's learning objectives are to identify elements of effective program models for community-based doulas and perinatal community health workers, core competencies and the elements of aligned training and curriculum design for community-based doulas and perinatal community health workers receiving reimbursements through Medicaid, the importance of cultural congruence for the community-based perinatal support workforce. Now I'll hand it back over to Dr. Moore.
Thank you, Yanti. And as a reminder, we invite all attendees to use the Q&A feature to submit your questions at any time throughout this session. Before I hand it over to our partner in this learning series, Yuki Davis from Every Mother Counts, as noted during session 1, this series is focused on the role of community-based doulas and perinatal community health workers as a strategy to address the alarming rates of maternal mortality and morbidity. We acknowledge that improvements will only be achieved through a multi-pronged approach. As we complete the learning series together and consider how to implement these models in our communities, it will be important to avoid, as I shared during session 1, the temptation of placing the burden of addressing all maternal health inequities solely on the shoulders of doulas and perinatal community health workers. They alone cannot solve the crisis. Access and coverage to doula and perinatal community health worker services in Medicaid is just one element of a multi-pronged approach that is needed to support system-wide transformation. For instance, as we shared during the first session, we encourage you to explore our midwifery portfolio of work as another example of the multi-pronged approach. Now it is my pleasure to introduce my colleague in this learning series, Yuki Davis, the Manager of Policy and Advocacy at Every Mother Counts. Yuki, thank you for your partnership and providing the grounding for today's session.
Thank you so much, Jennifer, and to all of you for tuning in to this second session. I'm so grateful for the opportunity to ground us before we turn it over to the true experts on today's panel discussion. Before getting started, I want to recognize that everything I'm sharing today, I've learned from community-based perinatal support workers and leaders themselves, and that my understanding is still and always growing. Next slide. Thank you. So as my colleague Nan Strauss shared during the first session of the series, titles and definitions are not standardized across the community-based perinatal workforce. This allows for programs to be responsive and adaptive to their communities, as well as the context within which they are operating. And despite this variability in what a program is called, what is overlapping is what makes community-based perinatal support unique. The dignified and respectful care they provide, the trust they build in the communities they support, and their comprehensive approach to meeting people's complex needs. Community-based doulas and perinatal community health workers lie at the intersection of doulas and community health workers in this sweet spot of community-based perinatal support. When in doubt, I encourage us to return to the definitions of these different roles included in the 2020 IMI report that was a part of this session's readings, which delineates the differences between doulas and community health workers, as well as community-based doulas and maternity or perinatal community health workers that sit at this intersection. Drawing from Advancing Birth Justice, another of this session's assigned readings, co-authored by Ancient Song Doula Services, Village Birth International, and my own organization, Every Mother Counts, we can understand that community-based perinatal support models build on the doula model of support, which includes foundational core competencies for community-based perinatal support. These include an understanding of the anatomy and physiology related to pregnancy, childbirth, postpartum, and infant feeding, employing different strategies for labor and pain management, providing emotional support and connections to resources, strategies to foster effective communication between clients and their care providers, including bodily autonomy, advocacy, and informed consent, and an understanding of evidence-based information to inform and support birthing people's decision-making. Community-based perinatal support programs add additional core competencies to this model in order to best meet the needs of birthing people at the margin, including addressing the intersectional needs of communities facing barriers and disproportionately poor health outcomes, including those enrolled in Medicaid. These core competencies include an understanding of how social and structural determinants can affect pregnancy, childbirth, and the postpartum period, as well as an understanding and awareness to refer to local resources, social services, and community-based healthcare systems that are available to support families, a knowledge of the reproductive justice and birth justice frameworks and how they intersect, cultural humility and cultural sensitivity, particularly through an understanding of the lived impact of and strategies to address structural and institutionalized racism, intergenerational trauma, and implicit bias, including through trauma-informed care, as well as the recognition of the intersectional needs of birthing people across the reproductive health spectrum and life course. These core competencies are foundationally shared by community-based doula and perinatal CHW models and represent what should be centered whenever creating a Medicaid program for reimbursement for community-based perinatal support, as these are the models that are best aligned to meet the intersectional needs of the Medicaid enrolled population. In order to create an effective Medicaid reimbursement program, one that supports birthing people and the most aligned community-based workforce, credentialing and provider enrollment requirements should reflect the core competencies or trainings that are actually needed for an effective community-based perinatal support worker to provide support to a client enrolled in Medicaid. Some general best practices, which will be expounded upon in the upcoming panel, as well as future sessions, include mirroring core competencies and required trainings to those that most appropriately support Medicaid enrolled birthing people, avoiding burdensome, cost-prohibitive certification pathways that can often serve as barriers for community members to become perinatal support providers. Because these are non-licensed, non-clinical providers of care, we can create provider enrollment requirements that are adaptive and aligned with the type of care provided by community-based perinatal support workers, like community-based doulas and perinatal CHWs, while also ensuring the safety of birthing people. Prioritizing Black-led, Indigenous-led, community-based training and certification programs and those that are included as recommendations for credentialing requirements, and overall being responsive to the intersectional lived experience of community-based perinatal support workers. We need provider enrollment requirements to be accessible and supportive for the workforce that is best suited to provide support to the birthing people that these benefits are hoping to reach. So in this, I wanted to uplift one example of how Medicaid reimbursement programs can be responsive and reflective of the core competencies and core values of community-based perinatal support by highlighting the creation of the Medicaid Doula benefit in California. While we'll be hearing more about California's model and its design and implementation throughout this series, I did want to highlight their provider enrollment pathways as a model for other states. Through deep engagement with community-based doulas in the Medi-Cal and the Department of Healthcare Services was able to implement 2 pathways towards becoming a provider eligible for reimbursement. The first is the training pathway, which requires a set number of hours of training in topics like lactation support, non-medical comfort measures, prenatal and labor support. And the second is the experience pathway, which honors and credentials doulas who have been practicing already in their communities and who have demonstrated skills and experience through their practice. These doulas must provide an attestation to a certain number of years of experience as a doula, as well as written testimonial letters from clients and providers. In these 2 complementary pathways, California is demonstrating what is possible to meet requirements from Medicaid for provider enrollment, while also aligning with the core competencies, trainings, and realities of being a community-based doula. I hope through this framing and the discussions to follow, we can illustrate a roadmap towards creating credentialing pathways that best support both the birthing people who will receive this critical care and the workforce supporting them. By being responsive to the community-based perinatal support workforce and aligning Medicaid programming with what is necessary for a community-based perinatal support worker to best serve their clients, I believe we can truly advance towards birth equity. Throughout this series, guests from different stakeholder groups will address how to work hand in hand with community-based partners towards equitable, effective Medicaid coverage of perinatal support. The roadmap this series builds will address both community-based doulas and perinatal community health workers, and we want to reemphasize these 3 key approaches. First, the importance of focusing on the services offered, the expertise, core competencies, and underlying approaches of a program or model, regardless of which term they use, as titles are not standardized across the workforce. Second, there is no single solution for Medicaid coverage of community-based perinatal support. Different communities have different needs, service gaps, strengths, and resources, and each Medicaid program is different, requiring unique approaches for each state related to doulas. By sharing successful practices and perspectives from diverse stakeholders, we hope to offer general frameworks and models, along with a menu of options to help inform the design and implementation of perinatal support programs in any state Medicaid program. And third, if there was one key takeaway from all of this, it is that the success will depend on building robust relationships where community-based partners are thoroughly integrated into the process of designing and implementing initiatives to keep their voices, wisdom, and experience at the forefront. Today's panel discussion will include an in-depth examination of the elements of effective program models and different strategies utilized for curriculum alignment with core competencies, so that state Medicaid programs can focus on implementation and collaboration with peer support and the community-based perinatal support workforce. I am now honored to introduce our session moderator, Belinda Pettiford, President of the Association of Maternal Child Health Programs. Belinda Pettiford has worked for over 30 years in public health and currently serves as the Chief of the Women, Infant, and Community Wellness Section at the North Carolina Department of Health and Human Services. In this capacity, she oversees the state's maternal health, family planning, preconception health, teen pregnancy prevention, sickle cell, and numerous programs focused on equity and birth outcomes. Belinda has provided leadership for numerous national, state, and local efforts. She co-chairs the Perinatal Health Committee of the North Carolina Child Fatality Task Force. The CFTF is a legislative study commission directed by the North Carolina General Assembly. Belinda also serves on the Secretary's Advisory Committee on Infant and Maternal Mortality and is a board member with the National Healthy Start Association. Belinda presently serves as the president of the board of directors of AMCHIP. She received her Master of Public Health from the University of North Carolina in Chapel Hill, an undergraduate degree from the University of North Carolina in Greensboro. Welcome, Belinda, and thank you so much.
Thank you so much, Yuki, for setting the stage for this awesome conversation today. And as I begin, I must say Happy New Year to all. I was in a conversation or in a meeting earlier today, and I was reminded it's okay to keep saying Happy New Year for at least the first 2 weeks of January. So I feel really comfortable saying Happy New Year to each of you all. I am thrilled to moderate today's discussion as we hear about the amazing work of our panelists and the work they're leading to support community-based doulas and perinatal community health workers. As we continue to strengthen our focus on perinatal inequities in our country, our states, and specifically in our communities, we know today's panel will share some of how this work is being implemented successfully as one component of a way to improve maternal and infant health. So now I'm excited to introduce this amazing panel. First, I start with Ozzie Nadiri. Ozzie brings over 18 years of experience in community advocacy, reproductive justice, and program development. She is a mother, licensed certified professional midwife, and family therapist, and co-founding executive director of Mama Toto Village. Ozzie is a fiercely dedicated woman who believes that by promoting a framework of justice and liberation, the barriers that impede optimal maternal and child health begin dissipating, giving rise to healthy individuals, families, as well as communities. She is a doctoral candidate specializing in organizational leadership and management with an eye toward the sustainability of Black-led organizations and cultivating innovative models of perinatal workforce development and care delivery. Next, I introduce Jessica Luan. Jessica is the founder and director of Colibra Corazon. She is a reproductive justice advocate, a community-based herbalist, a queer farmer in northern New Mexico. Jessica worked with TWA Women United starting in 2010 as a full-spectrum doula, childbirth educator, certified lactation educator, and served as the manager of the Indigenous Women's Health and Reproductive Justice Program at TWA Women United from 2015 all the way through 2022. And last but definitely not least, I introduce to you Sarah Covington Cobb. Sarah's works at the Center for Community Health Alignment, where she supports community health workers and the organizations that employ them through training, through research, fundraising, and technical assistance. Before that, she spent over 9 years managing a centering pregnancy prenatal care practice where her team implemented over 400 groups with over 4,000 patients during that time. She included training prenatal care providers statewide, as well as conducting extensive research. She says that community health workers are her heroes, and it's a privilege to work with them and for them every day. If you'll notice, we've placed in the chat a link to all of the speakers' bios if you want more information on them. Our distinguished panel will lead us in exploring the dimensions specifically of core competencies, training models, as well as cultural congruence of community-based doulas and prenatal community health workers programs to help us achieve our learning objectives for today's session. So let us dive directly into this discussion. And I'll start with the first question, and this question is for each of you, each of our amazing panelists. Each of you represents different training models for both community-based doulas as well as perinatal community health worker perspectives. Please tell us about the program and training models you lead and how they address issues around disparities for advancing birth equity. And we're going to start with Ozzie.
Thank you. So just a little bit about Mama Toto. So we were founded in 2013 by Cassietta Pringle and myself. And Mama Toto Village is a Black-led community-based organization whose commitment and mission are really anchored in uplifting the expertise, the knowledge, and experience of Black people while offering training and professional development that edifies the care that is required to support Black birthing people and their families across the continuum of pregnancy, birth, and parenthood. We serve, since we started this organization, 2,500 birthing people. Most of our clients are Medicaid eligible. We have been able to maintain a 0% maternal mortality rate in the delivery of our home visitation program, which is an innovative, promising practice. And that program serves about 350 people a year. Our perinatal health worker training, which we have been delivering since 2012, is a continuation of this movement for us to reclaim and restore our ways of knowing and being. Our training is about 200 hours long. That is all in person. And the most unique aspects of our workforce training is the focus on the specialty of perinatal health in a community health worker model that's grounded in both reproductive and birth justice. Justice for us is our anchor, it's our North Star. For us, it goes all the way towards seeking liberation. At Mama Toto, we define perinatal community health workers as a type of CHW that specializes in the comprehensive care of pregnant, birthing, and postpartum parents. And for us, there is a clear distinction between PCHWs and doulas, specifically around the acuity of the people that served and the delivery of care coordination and care management. Our training has been a stepping stone for Black women into midwifery, into being clinical lactation consultants, nurses, OBs, family docs, you name it, our people are there. And so we really see this as a transformative model that to date, we have trained over 215 women who either work at our organization or who are working out in the community.
Thank you so much, Aza. And now we'll go to Jessica.
Thank you, Belinda and Aza. It's wonderful to hear about the work that you're doing there at Mama Toto. I'm here to talk today a little bit about Tewa Women United and the Yabika Doula project, which I helped to manage from 2015 to 2017. I came into doula work by working with the YBK Doula project, which started in 2008 as a response to our intention to address the the childhood sexual violence that was happening in our communities. And we really felt that coming into families from the very beginning and helping to create attachment and bonding could help to address the high rates of child sexual violence that we were seeing. And so we did start the YBK Yabika Doula project. And Yabika is Tewa for helper of the mother. And at the time, we began to train with different programs that were happening throughout the country. We brought in Health Connect One, DONA, CAPA. We were able to train with Shafia Monroe, really had some amazing trainers. But what we saw was that there was a lot of issues that were happening in our own communities that were not being addressed by the other trainings that were coming in from out of state. And so it was always our hope and intention to create a training of our own. And in 2015, we began to do research around all the different trainings that were happening. We looked at all the core competencies, training models, and then sat in a series of community conversations where we sat with our elders, our midwives, our other doulas, our young people, and really wanted to learn from them, what is it that you need from us to address the different issues that are coming up in the perinatal period? And from there, created our own doula training and curriculum. And that training takes place over 7 months. Each month focuses on a different topic. And the first month really kind of sets the stage by grounding in community care. From there, we look at issues around reproductive justice and birth justice, intergenerational trauma, resiliency practices, cultural humility, and then kind of set the stage to go deeply into the full spectrum of reproductive health and care. So I'm really excited to be here with you all today, and I'm sure that we will continue to learn more from each other. Thank you so much.
Thank you, Jessica. Greatly appreciate that. And now definitely we're going over to Sarah.
Thank you. And it's just such an honor to be in the same Zoom room with these people. I'm so excited to be participating in this. So here, what we did in South Carolina is we started with the foundation of the core CHW core competencies. The CHW Association, the South Carolina CHW Association, and our CHW Credentialing Council has really carefully and thoughtfully developed these core competency trainings and accreditation process, and they're based on the C3 projects, core quality skills and roles for CHWs. So we meant for the perinatal specialty, the perinatal training for CHWs to be like a specialty track on top of that core competency. So the perinatal CHW training is for CHWs who have already gone through a core competency training and are certified as CHWs. So one of my colleagues said it's kind of like if you go to college, you have a major. So if you are a CHW and you want to major in the perinatal field and you want to work with families during that perinatal period, this is kind of a top up in addition to the training that you can get. So with that in mind, we have a CHW ambassador program here in South Carolina in which CHW leaders in our state come together in cohorts to help us keep the CHW voice engaged and involved in any decisions and policies around CHW. So I went to the CHW ambassadors who had experience in perinatal, in the perinatal field, and I said, what do you wish you had known back when you were starting, right? What advice do you give new CHWs in this perinatal world when you're working with families during this period? And what core competencies do you need to revisit and re-emphasize over and over again? So they really fed me a lot of insight to work with when we have kind of developed this specialty track.
Thank you so much, Sarah. And just hearing your opening remarks with this first question, it's clear that you all are clearly engaging, individuals with lived experience, but you're also engaging perinatal community health workers and doulas as you're doing this work, which is so important for us to always remember. So we're going to go on to the next question, and I'm going to direct this question to Aza. Aza, you are a midwife. Your organization has a multi-pronged approach, as Dr. Moore referenced in the opening of this session. Can you tell us how your organization worked with Medicaid health plans to reimburse a comprehensive set of services, including those of doulas and perinatal community health workers?
Yeah, so our home visiting program is 100% funded through our contracts with Medicaid managed care. Our home visiting program is also staffed solely by perinatal community health workers. For us, again, as I shared earlier, the clients that we're serving require people who are more comprehensively trained. And in DC, there are 3 MCOs plus 1 that is for children with special needs, and we have contracts with all of them. The MCOs did approach us in terms of getting that relationship started. So we're about 8 years into that relationship. Definitely have learned a lot along the way. But as back in 2015, when were a young community-based organization, this funding for us really supported the growth and the sustainability of the organization, as well as the program. And it really allowed us to compensate our staff in a manner that was aligned with our vision of economic justice. What the MCOs fund is the home visiting, case management, care coordination, labor support, lactation, mental health services, as well as extended postpartum care. That includes postpartum for daytime and overnight support. Our contracts are both fee for service and capitated, which means that we're paid the same rate every month for a certain number of members. We do have a lot of intensive and extensive engagement with the MCO care managers through case meetings. Most of that are for our clients who do have complex needs. And what we know is that our PCHWs and our perinatal care coordinators are really filling gaps that are present in a delivery of telephonic case management, which is common in Medicaid managed care practices. And the relationships that we have had and continue to have really enhance our ability to support our clients and address the concerns that they are presenting with in an expeditious manner.
Thank you, Aza. Thank you so much. And I noticed some questions are coming in. If anyone is in the webinar, if you do have questions, if you'll take a moment and put it in the Q&A section of the webinar chat, that will be helpful. Thank you all. So the next question is for Sarah. So Sarah, we would love to hear more about the toolkit you helped develop for perinatal community health workers with a program there in South Carolina. It will be great to also learn more about the best practices you will lift up for integrating these tools into Medicaid covered doula and perinatal community health worker services.
Yes, absolutely. So the real strong cornerstone of our work is collaboration. So we have four different organizations that are in the perinatal CHW field in South Carolina. And we just wanted to be together and work together, support each other, lift each other up, learn from each other. And so we have gotten together. We worked with the CHW best practice toolkits that are already out there. And we said, all right, well, what do these mean? What are special considerations in the perinatal world regarding this? And that's how we kind of put together that toolkit. There was a lot of sharing, a lot of soul searching for this, putting together replication indicators that were very meaningful and helpful to others. Some of the best practices that we highlight, that I mean, they're all there in the link, but the ones that I would highlight were our full scope care. Let the CHWs be CHWs, like let them do their full work. Don't confine them to an office. Don't confine them to the goals that you set for their participants. There's a lot of power and potential in perinatal CHW work, and so you don't want to confine it, right? Also, the shared lived experience. There's a wide field of home visiting programs out there. What the CHWs offer that's unique in the perinatal time is the shared lived experience, that peer-to-peer trust. And so you always want to make sure you're hiring somebody from the community that you're prioritizing, and that my colleagues would say the CHWs have a PhD in their community, right? Like they know, they know. And integration. So in the perinatal field, like when I talk to my colleagues that are still working in OB practices, they're really overwhelmed. I mean, burnout is huge, and they're overwhelmed sometimes with their patients' really complex health problems, really complex social challenges, and it can be really, really hard for them. And I'm like, let the CHWs help. That's where they shine. Bring them onto your team, integrate them into your team, talk to them, work with them, and there's a lot of ways that they can really help you work better.
Thank you so much, Sarah. And now we're going to go over to Jessica, because Jessica, we know you have worked with Tijuana Women's United for quite a while. So can you please share the highlights of the Tijuana Women United report and how it can be used to promote access to and use of the community doula model in Medicaid?
Thank you. Tijuana Women United created and wrote the Expanding Access to Doula Care report and released it in March of 2020 as a response to our own questioning around different pathways and models for Medicaid reimbursement for doulas. At the time, we were looking at lots of different options and opportunities for our families to be able to access doula care. The TW model was a low to no cost doula care approach. We never turned anybody away who needed access to that type of care. And, you know, at that time, there was a lot of states starting to really engage in that conversation around Medicaid reimbursement. And for us, we knew that there was a lot of challenges that our rural doulas, our Indigenous doulas, our BIPOC communities were facing when it came to being able to engage in that Medicaid system. And so we started to look at different legislative pathways and really just knew for ourselves that at that time, we did not have enough information to make an informed decision. So that report came from our own research, conversations that we were having, as well as the inspiration that came out of the Advancing Birth Justice report and the report that came from Black Women's Blueprint on the sexual violence to maternal mortality pipeline. All of that really kind of informed us. And you know, we really wanted to highlight the aspects of community-based doula care, the importance of survivor-centered work. For us, it was important to really talk about the importance of a thriving and living wage for doulas, having low Medicaid reimbursement rates was just not going to work for people in New Mexico, as Yuki stated earlier. And it's so important to make sure that people are really being paid for the work that they're doing. You know, and in addition, we wanted to talk about Medicaid reimbursement, but we also wanted to talk about other pathways to make sure that reciprocity was happening. And so that report was really kind of pulling in all of those pieces. And I'll say that we launched that report on March of 2020, the same day that the entire world shut down for COVID. And so I'll say that there has been so much learning that we as New Mexico has done in thinking about what doula care is, what it looks like as in the virtual manner. The virtual COVID doula care really shifted everything. And so, yeah, just to say that we are really continuing to pull from our own learnings in that report. And as we continue to embark on this Medicaid pathway, taking those learnings and kind of moving forward. So thank you.
Oh, thank you, Jessica. And now we're going to go back to South Carolina over here to Sarah. So Sarah, recognizing your research and expertise on workforce development, what role do you think Medicaid agencies, health plans, and providers play in supporting the development of perinatal community health workers that support equitable birth outcomes?
Well, my first response is yes, you do. You want to do that. You want to work with CHWs if you're not already, like the partners that Oz's team is working with. My other first response is to listen to the workforce. The CHWs like to say nothing about us without us, right? Like I think Jessica said that earlier, that we have every state, including South Carolina, has, or most states have a CHW association. We have the National Association of CHWs. Here in South Carolina, we have a CHW association and a CHW credentialing council. We have CHW ambassadors who are leaders in the field, and they come at them with your ideas, with your drafts, with your concepts, and we'll make sure that we'll get it done, you know, in a way that's going to help avoid obstacles or problems or delays or anything like that. Just the CHWs are amazing, resourceful, problem-solving, creative people. So get them on your side and listen, listen to what they have to say. The other thing that's come up a couple times is that concept of full cost accounting, that you don't just pay for an encounter, you don't just pay for a salary, but strong CHW programs incorporate travel, time for mentoring, time for professional development, time for ongoing training. So pull that all in for that full cost accounting. Again, there's such a good, strong foundation as well that you can utilize as far as the C3 project, the common indicators that are coming out, lots of best practice toolkits. The field has really advanced so much in defining what we are and what we do and how we do it, that there's a lot to build on there.
Excellent. Thank you, Sarah. Again, listen. Our next question, I'm actually going to ask Aza and Jessica both to respond to, but I'll start with Aza. As you reflect on the work that you're leading, can you share more about the importance of cultural congruence in community-based perinatal support?
Yes, for us, culture is everything. And Wade Nobles, he defines culture as a general design for living and patterns for interpreting reality, right? And so for us, it's the lens that we use to guide our model of collective care. It informs how we support our staff and our clients, how we build community. The policies and the aesthetics of our space are all anchored in our understanding of culture and why that's so important as a transmission. The other part of that is understanding, and several people have brought it up today on the panel, but that our staff 100% reflects the community that we serve at all levels of the organization, including our board. We know that much of the literature about community-based support and services and interventions tells us that people best receive information and support by people who look like them, people who speak their language. And so for us, that is an authenticity that you can't duplicate, right? You can't replicate that. That is unique to each individual space, each individual community, and even subculture. The other thing is that when we think about our theory of change, cultural proximity, culture within itself, our 3-generation approach, our training, like culture really emerges as the center of all of that and the thread that inextricably links all of this work together. And so when we deliver our training, we continue to be guided by the culture of the prioritized community. We make sure that how we show up is a direct reflection of what they need continually. And as we prepare for the replication of our home visiting program and the scale of our training, we are putting together both a cultural replication and adaptation guide that will be available for people to model our work based on the needs of their community, not based off how we think Black people should be cared for or Indigenous people should be cared for. That again is unique to each individual place and space.
Thank you. Jessica, could you chime in as well?
Absolutely. I'm so excited to see what's coming out of Mama Toto. That's really beautiful. And I think when we talk about cultural congruency, you know, Sarah, you said it too, that every community, we're our own experts. And I think about here in New Mexico, you know, birth always happened in the home and people were cared for by their sisters and their aunties and their, you know, the people within their community. And we know best how to care for each other. And as, you know, systems of colonialism and white supremacy have come in and taken out those traditions and those teachings and those ceremonies away from birth, we've really had to do a lot of work around reclaiming them. And, you know, in Table Women United, they talk a lot about the butterfly model, which is this aspect of kind of incorporating those traditional practices, that ceremonial space, bringing in all of that ancestral knowingness, and then incorporating it in this modern day and this medical systems that we work within, and how doulas and perinatal community health workers and all people who are working within community really have to continually flow between those two worlds. And I think it's really important that, you know, any training models that we bring in, any training models that we're uplifting, hold both of those spaces. I think that that's when we see the most beauty that's coming from our work. I just want to say on top of that, that a lot of the languaging, a lot of the materials, the curriculums that come into birth workers' spaces, into doula care, are very cisgendered, are very heteronormative. And I think it's important when we're talking about cultural congruency to remember our queer and trans kin, and to not only just bring in little pieces and highlight little aspects or maybe to switch our language, but to really make sure that any kind of materials and modeling is being brought in by those folks, making sure that they are really bringing their lived experiences in, and that we are being inclusive of all our community members, all of our family members. So thank you. Thank
you both so very much. This last question that I'm going to ask, I really would like for each one of you all to take a chance, an opportunity to respond to it. And the question is, we're here today to inspire action. That is our focus. We want movement. We want action. Now that you all have shared insights about the models that you have led in your community, before we open this up for the audience, we want to ask each of you this specific question. What is your top recommendation for those who are implementing Medicaid, doula, and or perinatal community health worker support in their states, in their communities? And we'll start with Aza.
Yeah, my top recommendation is to ensure that folks have the infrastructure, the community connections, the resources, the appropriate training and knowledge and capacity to serve populations that may be medically and socially complex. What we know is that states are passing doula legislation, and what is being uplifted and promoted are white-led trainings that have historically neglected the inclusion of reproductive and birth justice as frameworks, racism as a root cause, have really made the experiences of Black and Indigenous people invisible. And so doulas are important. Everybody deserves to have a doula, but we also really support, I support and my organization supports economic investment in organizations, right? Like Tewa, like Mama Toto, like Root, like Ancient Song. There's so many that I can name, whose services are really designed for people who are most marginalized, right? And whose services are culturally anchored and rooted and are being led by the people who come from the communities that are being served. And so that would be my recommendation, that the people who are leading the work need to be the people who are from the community.
Excellent. Thank you, Aza. And Jessica?
I think it's really important, again, just to uplift how important it is to have both doula and community-based organization input from the development through the implementation of any sort of Medicaid reimbursement process. It's important to, once again, ensure that there are different pathways for not only for training, but for experience pathways for people who have been doing this work for a long time, but may not have the certification as being required by some states. It's important that when we're looking at the definition of doula or a perinatal community health worker, that we are inclusive in our scope, so that we're thinking about full spectrum work. Here in New Mexico, we know that at least 76% of people, regardless of faith, based beliefs, believe that it's a person's right to choose, and abortion and reproductive choice continues to remain safe and legal here in New Mexico. So we want to make sure that doulas are able to provide services regardless of reproductive outcome. And finally, how important it is to provide a thriving wage for our doulas and perinatal community health workers.
Thank you, Jessica. And Sarah, we'll move over to you.
I would just
respond to
echo
this.
what my other panelists have said. I don't have anything else to add other than the CHW qualities and skills and roles have been well described. And pay attention and be true to those.
Thank you for wrapping it up, Sarah. So I definitely want to thank this panel for your response to the questions that we've started with, but I can see that our Q&A is filled with questions. So hopefully if you'll give us a few more minutes, we'd like to take the time to answer at least a few of the questions that are coming in from the other people in the audience. And for those questions we don't get to, we will work on a Q&A document to try to get a response posted as soon as possible. So the first question that's coming in from the audience is, what advice can you offer for those who are in a state without strong support to expand Medicaid coverage for doulas and community health workers? And then the second part of that is, how can we convey the business case and social return on investments? And why don't we start with Jessica this time, and then we'll go to Sarah and then Aza. If you, either of you.
Here in New Mexico, as we started to really look at implementing Medicaid reimbursement, one of the things that we knew and understood was that due to the vastness of our state, the rural nature of many of our communities, it was important to have a central hub for doulas to be able to advocate for their profession, communicate with each other, continually educate themselves. And so we created the New Mexico Doula Association. And that New Mexico Doula Association at this point is really being on the forefront to advocate for Medicaid reimbursement, to make sure that it's going to provide all those things that I spoke about a little bit earlier. And I would just say, like, if states do not have something like that already in place, having a community-based organization that is holding that for doulas is very important. And I will pass it on to my other panelists.
I am interested in hearing from Aza too. I know because of the partnership that you've got with the Medicaid MCOs, I think that's a really strong model that I am interested to hear about. But also, we stand on the shoulders of the strong leaders that we have in our state that have been out there doing this work with no reimbursement from Medicaid. And so what we can do is point to those and point to their excellent outcomes and hard work and the impact of what they've been doing out in the community and say, you know, this needs to be expanded. This has so much potential.
So a part of like when you're thinking about like ROI, like usually that's anchored in data. And so having the data, and unfortunately, oftentimes you have to do the work and you have to have the data, and that becomes your ROI. And that's really what happened in our situation, is that we were already doing the work. And so we had the data to validate and support what we were doing, right? And so we were able to speak to whether it was preterm birth outcomes, we were able to speak to the cost of the cost of the MCO for a NICU baby, the cost for a cesarean birth, the cost when a person has perinatal mood and anxiety disorder, right? Being able to put a number to that, being able to share data with the MCOs. Unfortunately, data is not always transparent and accessible to the community so that you can use it and leverage it, but being able to access in the ways that you can data that is available. Usually you can look at HEDIS measures for your states and see where they are ranking on the scale, and then present your model in a way that speaks directly to that. That would be a suggestion.
Thank you so much. And again, we've got several more questions, so we're going to just try to answer a few of them. So the second question I'm going to ask is, what are your recommendations for fostering strong relationships between licensed providers and non-clinical perinatal workers based on understanding of the best practice trainings that you have started? So just thinking about that relationship piece, and I'll open it up to either of the three of you.
I will say a part of that is, again, going back to how the person was trained. Oftentimes there is an antagonistic relationship, and depending on your training, how you are trained to relate to providers, how you are trained to see providers, how you are trained to see hospital-based care. And yes, there are bad apples, right, in all bunches of people. And so being able to see providers as collaborators, right, as colleagues, that's how we train our workers and our PCHWs, is that the provider, like, you are a part of the care team, number one, and the provider is your colleague. And because we train them in such a rigorous way, they're able to speak the language of that system, which often lends itself to the provider respecting them. The other part is organizational capacity. So those of you who are in organizations, having people to do that outreach and engagement to cultivate those relationships. You should steward providers like you steward donors, right? Like, everything is about the connection, like getting to know you, getting to know your organization, getting to know your work, and it does go the distance. And then treating, like we expect that bi-directional exchange of respect. So showing up respectful while also holding people accountable. Both can exist and both can be true. But I would say that it goes the distance in terms of how to cultivate and then steward that relationship with providers.
I
I
love
don't know,
that.
Jessica, Sarah, either one of you have anything you want to add to it? That's fine. I didn't mean to cut you off, Jessica.
That's okay. I would just uplift what Azza was saying and include, in the doula training, we make sure that we're bringing in local area midwives. We're bringing doulas to the hospital where they're meeting the nurses and the OB care team. We're really making sure to kind of foster those relationships from the very beginning. And on top of that, are having quarterly conversations between the three different professions to build understanding, relationship, to talk about scope of practice for different potential emergency situations that might occur with the client, whether that be a home birth transfer or shoulder dystocia, or even just to have those conversations around, like, what does a doula do? What is the importance of midwifery care? And I have found that those conversations have done more in our community to foster a positive relationship between licensed care providers and doulas, more than anything else, even to the point where during COVID, when all the hospitals shut down and doulas were seen as visitors, our doulas that were trained through our program were able to go into hospitals and continue to provide care because those relationships and that trust building had already been put in place. So I would say communicate and communicate more than anything.
Thank you so much, Jessica. And one final question that I'm just going to ask Aza to take a quick 30 seconds to respond to, if at all possible. What are the best practices for addressing the impact of racism in training models and core competencies? If you'll just take a quick few seconds to respond. I know it's a very long response.
Yeah, I mean, the short is that, again, training models that are community anchored and rooted need to be the ones that are uplifted and invested in. Like I said in my response earlier, what is being upheld as the gold standard are white-led models who have monetized cultural competency in a way to benefit from this racial reckoning that's happening in the conversations that are moving. It doesn't mean that people can evolve, but you shouldn't evolve at the expense of taking resources away from Black organizations, Indigenous organizations that have been doing this work for years within their community. So to me, the best practice is to put the resource at the community level. And as other organizations, right, to me, white organizations should train white doulas on how to be better allies and supporters, but need not to step in the way for the people who are already doing the work. Again, doula work, birth work is not new for our communities. We've been doing it before there was a name to it. We were already doing it. And so I do think that those continually have to be what is put forward as the gold standard and not the other way around.
Thank you so much, Aza. And again, I didn't mean to cut off Jessica. Sarah, if it's anything you want to add to that. Looks like you're shaking your head in agreement. So thank you both so very much. We are pretty much out of time of responding to questions. And again, I must thank our panelists for taking times out of your very busy schedule for this discussion today. If everybody could come off of mute and clap, they would, because you all have done an awesome job. You are, and please know, I am sure people will be reaching out to you for follow-up information. I know my role here in North Carolina, we're in these same conversations with our sister agency over at Medicaid, so as well as with doulas and members of our General Assembly are looking for ways to improve this. So on my end, it has truly been my pleasure to join you all today. I look forward to remaining connected with you all. And at this point in time, I'm going to turn it back over to Jennifer. Thank you all.
Thank you, Belinda. Wow, I do not want this panel discussion to end. And as Yuki had shared in the beginning, we're constantly learning from community-based perinatal support workers and leaders. And truly today, and the panel discussion is a great example. I'm personally walking away having learned so much, and I'm grateful for their time and sharing their expertise with us today as part of this series. And thank you again, Belinda, for serving as the moderator for this really robust conversation. Again, having learned so much from the panel. As you can imagine, we received a large number of questions like we did the first time, and that is a product of the large number of participants we have for this series. We were only able to get to a few of your great questions, but just like last time, my colleague Yanti said at the beginning of the session, we're going to send all of your questions to our presenters. They're going to have a chance to respond to them in written format. We will create a Q&A document that will be sent to you as part of the post-session materials. Every question will be answered. So thank you again for submitting those questions so that we can create that FAQ document. So with that, I'm going to hand it over to my colleague Yanti to go over a few wrap-up items before we close out the session.
Thanks, Jennifer. And I just want to thank all of the panelists. I learned so much just from this short time. But at this time, we want everyone, you're going to receive an email with the link to complete today's brief 3-minute feedback survey. If you did not receive the email, you can contact me. My email is listed on the slide for your convenience. We've also shared a link to the survey in the chat box. So you can begin to complete the survey as we wrap up. As a reminder, completion of the evaluation is required as part of the participation in the learning series. We actively review and incorporate your feedback into our future sessions, including planning for the topics for sessions 7 and 8. Finally, all materials from today's session, including the recording, will be made available to you on the IMI website about 2 weeks after the presentation date today. Session 3 of the Doulas and Perinatal Community Health Workers and Medicaid Learning Series is Contracting, Credentialing, and Payment Mechanisms in Medicaid. And it will be held on Thursday, February 2nd at 3 p.m. Eastern Time. If you haven't already, please remember to add Jennifer Moore to your email contact list to ensure that the series emails are not sent to spam. Her email is also posted on the slide. I just want to say thank you again for your participation, and we look forward to seeing you at session 3 on February 2nd. Thanks so much.